Welcome to episode 29, and once again, my apologies for taking so long to put this one out. I'll be moving back to the West Coast soon and plan to devote more time to podcasting and blogging. In this episode, I'm talking with Ron Fellman from Glaucoma Associates of Texas about the Fellman Fluid Wave and its clinical implications in glaucoma surgery. I'm Rob Schertzer, a glaucoma specialist and educator with more than 20 years in clinical practice, and we're talking about glaucoma. Welcome to the show, Ron Fellman.
Thank you.
And today I'd like to talk about something that I really hadn't heard of until the American Glaucoma Society meeting that we're in the midst of now, and that's the fluid wave. It seemed to come up several times each day, and it was always referred to as the Ron Fellman Fluid Wave. So I don't know if you're going to go down to in infamy like the Drance hemorrhage.
You never know. You never know.
So, yeah, so let's talk about that. So
Sure.
when do you do that? Why is it useful in glaucoma surgery?
Those are all good questions. So I'm glad it was brought up because it does have a use. But first of all, let's discuss, what it is and what it means. So I think,
Sure.
It's associated with today mainly microinvasive glaucoma surgery where you're doing something to the canal. So it has to do with the conventional outflow pathway. Not uveoscleral pathway, but just strictly the conventional trabecular outflow pathway.
Right.
So what it is it's if you see a wave in the operating room, we'll talk about that. It's evidence for intraoperative patency of the conventional outflow system. So it's a pretty simple thing, which I like. It's easy to elicit.
So this does not involve any dye injection in the eye?
No dye.
No special lighting?
No special lighting, exactly. It's simple, because I think simple. That's what I do. And the thought behind it came probably 10 years ago when we were doing viscocanalostomies and canaloplasties. So back then, where you would unroof Schlemm's canal,
right,
during for example, a canaloplasty, but the visco canalostomy actually is what it's called, came before, but either one.
Right, and Stegman had those videos he would show of those high magnification microscope views. Where
Right.
you would see things flowing through the outflow pathway.
Yeah, that's right. And but those were like gonio views. So if you do a canaloplasty, you basically unroof Schlemm's canal externally, right? Like 10 years ago, whatever. So I thought it was really exciting to see Schlemm's canal when you unroofed it. It was really exciting. So what I did is I would inject BSS with usually it's a grease auger cannula, or you could really just use a 30 gauge cannula, and just slide into the side of the canal because we'd opened it up, right, and injected BSS to see the laminar flow. I wanted to see the flow go out.
Yep.
Because I thought it would just be cool. And the first few cases, I could see it. And it was really exciting to see the outflow system just be washed out by BSS.
Right. I actually didn't really believe Schlemm's canal existed until I did viscocanalostomy.
Right.
To me, it was a mythical beast.
Yeah.
It was like a unicorn or something.
That's a good point because we can't visualize it no matter how hard we try in the clinic. Except indirectly, maybe blood would go in on gonioscopy. But anyway, so I was excited about that. I would just kind of routinely do that. But I found out after I did a few more that I would inject BSS and nothing happened. There was no flow into the veins right adjacent. And I went, oh no, I'm in the wrong spot. I did something wrong. I didn't know what to think about it back then. Right. It didn't compute exactly. Just, you're in the heat of battle, thinking about the trabeculo-desmotic membrane that you had to deal with next. And so, I registered it in the brain and said, okay, I don't always get flow. And I didn't know what that meant.
Did you think you weren't in the canal?
I did think that. Okay. I didn't know what to think. Yeah. I couldn't compute it exactly. And then, canaloplasty, as microinvasive surgery came along and working on the canal more internally, then we didn't go through the sclera anymore over the years, because we've been doing, for example, trabeculotomy ab internal circumferential for 5 years.
Right.
So that's a long time. So Trabectome came along, which was very elegant, very innovative procedure where you could ablate, the trabecular leaflets that would typically close back during a trabeculotomy.
Right.
You could ablate that, and that was the beauty of that instrument. That Minkler did some work on it. Barveld invented it. But that was the beauty of that technique. So I'm in the operating room. This is about 5 years ago, and we opened up the trabecular meshwork, and we're having a lot of fluid go in the eye during, for example, a phacotrabectome.
Right.
So I said, I wonder if you can see the BSS going into the distal collector channels like we saw with canaloplasty. Well, luckily, it was a case that you could see it, because I learned later that, there are cases you don't see it. So, you purposely have to do a few things to see the wave. Number one, I put the patient in about a 5-degree reverse Trandelenberg. And that's going to decrease the episcleral venous pressure just a little bit. Because if your episcleral venous pressure is high, you're not going to see BSS going down through it. And that was one thing. The other thing we do when we're getting ready to try to see is there BSS going down through the collector channels is we raise the bottle to as high as it goes. Okay. And I think that, that'll increase the pressure a little bit. So, it's not very physiologic at all. But, there's a lot of pressure in the eye, even just during phaco when you have fluid going inside the eye. So anyway, the key is reverse Trandelenberg, and you do your trabectome. And by the way, if you're looking at the collector channels, the episcleral veins, and you're just doing a phaco, you don't see any flow into the episcleral veins because you didn't open the canal. If anything, when pressure goes up in the eye, trabecular meshwork will normally slam up against the back wall and herniate into the collector channels, and there's zero flow. So you don't see flow just during a phaco, because some people kind of got mixed up on that. So let's say you do your trabectome. I typically do it first, and then let's say you do your phaco. So during the INA, during phacoemulsification, is when I will try to see if there's blanching of the episcleral tissue. And it's always going to be adjacent to the trabectome site if you're going to see it.
Okay.
Which kind of confirms the fact that there's very limited normal circumferential flow in the canal. It's like zero, I think. It's really, really minimal.
Yeah, so it's really segmental.
Totally segmental, yeah. So what I will do is I'll have everything ready. I've moved the scope over more towards where I'm looking at the limbus, not right over the pupil. So I've moved the scope over a little bit so I can visualize the adjacent area to the trabectome. I'll take my foot off the foot pedal. So now we're letting the pressure in the eye drop. Okay? And what happens is you'll see blood reflux at certain clock hours, sometimes, not always, but sometimes. And I'm going to really look in that spot where I saw the reflux, because in reality, that blood is refluxing from Schlemm's, from the episcleral venous system into the anterior chamber because the pressure's low. And I'll look right, especially in that spot. And then, then I floor the pedal, hit it all the way to the floor. And then you'll just get a rush of BSS into the anterior chamber. And if there's a connection between the anterior chamber and through Schlemm's canal, because you've opened up the canal, you just now have to go into the back wall of the canal. If the collector channel entrance is patent, and if the fluid, the BSS, how does it get to the episclera? That's just the key that we learn. Normally, your conventional outflow pathway, the majority of it is, you have about 25 to 35 collector channels. So let's say one of them's working. Right. And the fluid then goes, so it starts at the collector channel entrance, and then it goes into the deep interscleral plexus. And then the fluid goes into the interscleral plexus, and then the fluid goes to the episcleral venous plexus. So it has to go all the way through those the two deep ones to make it to the episclera. Now, granted, there are 4, maybe 3 or 4, maybe 5 veins of Vasher, which are kind of, as people have said, they're the superhighways. So they bypass that deep plexus. And they go straight from the canal to the episclera. Okay, so you can see in some cases, if you're lucky, and you might see one of those bigger veins, the fluid in that case does not go through the deep plexus. It does not go through the mid plexus. It goes straight to a superhighway.
Got it.
Okay. But in general, what you see over the clock hours that you're looking at is, there'll be maybe 7, 8, 9 collectors in the area that you opened. And the question is, or I shouldn't say the question, the point is that some serious investigators believe that some of the downstream collector channels are abnormal in primary open-angle glaucoma. Nesterov showed that, Deverak-Theobald showed that, Goldman thought that in many cases, Asher thought that. If you go back and read the literature from the 50s and the 60s, a lot of these people said, we think glaucoma is not so much the meshwork, but right behind the canal.
So not juxtacanalicular tissue?
No.
Okay. That's
totally correct. And, that's all been lost, that old reading,
Right.
And obviously I started to read more about this when I realized that in some patients I would see a diffuse blanching of the episcleral tissues with BSS running down there when we elicited the wave. So when we would raise the bottle, let the fluid run in the eye and look. And we would see sometimes 4 or 5 clock hours it just turned white. And then other cases, nothing. No blanching. And the blanching occurs because BSS ran all the blood out of the tissues as the wave went through. Does that make sense?
Yeah.
Yeah.
The question is then, do you want to optimize your treatment to improve the flow through those areas that have the collector system that's working, or do you want to do something to improve the flow where you don't have good collector system working?
I think we don't really know the answer to that perfectly, but Haiyan Gong, I was talking to, who's done an incredible amount of, great laboratory researcher in outflow in Boston, that she was doing an experiment where she was trying to increase flow through angle work, canal work, in, let's say, the temporal area.
Right.
But there was still less resistance to flow nasally, even though she'd worked on the temporal part of the angle.
Right.
So the aqueous it wants to go out the path of least resistance, period.
That's what I would think.
So anyway, what I wanted to get to as well is the fact that if you see a blanch of BSS on the episclera, what does that mean? It means that the deep and the mid plexus are open.
Yeah.
They're working.
So does the Trabectome work better in the patients where you see the wave compared to patients where you don't see the wave?
Yes, and we did report that, and I'll tell you about that in a second. But what I wanted to say was it's kind of like a poor man's angiogram.
Right.
The wave. So in a way it is angiography, right?
Yeah.
But it's with balanced salt solutions.
Yeah.
I don't know exactly what you would call that.
Yeah, no, it's like putting in the coronary stents, and now you have 100% flow instead of any occlusion.
Yeah. So anyway, we did notice this, and we did notice that the wave was very diffuse and marked blanching. Now, the blanching represents the fact that if it's over several clock hours, that the deep plexus works, the mid plexus works, because that's the only way to get the BSS to the episclera. But it means that whole deep network is functional to an extent. There's some capacity. That's very different than the superhighway, where all of a sudden you see BSS run out a big vein.
Yep.
Very different. Okay, because we found after looking at everything that the blanching correlated best with the lower pressure. So we went back and looked at all our phacotrabectomes. We did it masked, and we had a grading system. It's very arbitrary, but it's the best we could do. We reported in ophthalmology, and what we found was that patients who had several clock hours of blanching, their average pressure was 11.9, maybe 12, on one medicine.
Right. The
patients who had minimal to trace wave, their average pressure was 19 on 3 medicines.
Wow.
And the reoperation rate in the patients who had significant flow, 4, 5, and 6 clock hours was 0. The reoperation rate for further glaucoma surgery, I should say, was 33%, 36% maybe, in the group that had a poor wave. So it gives a surgeon a little bit of a feel for, how much trouble you're going to be in down the road. Now, it's not exact. Viscoelastic may mess up some of the wave, or maybe the viscoelastic gets clogged in there. Because some people that didn't have a great wave, maybe it was moderate, did better than I thought. Right. Now, the other corollary is patients that had a great wave, occasionally you'll see a failure there. Not a total failure, but their pressure's not as low as you thought, and they had aberrant wound healing.
Okay.
So those patients get granulation tissue in their canal. So we haven't learned how to modulate wound healing yet after microinvasive canal surgery. It took us 50 years to learn how to modulate wound healing with a filter. Our modulation of wound healing with canal surgery is 0.
Right.
So we got a lot to learn there. But that's the essence of it.
You would think there would be less risk of granulation tissue formation with something like a trabectome as opposed to the procedures where you're just ripping through the canal?
Don't know.
Through the meshwork?
It's a great question. Yeah. We don't know what is the best way to open the canal, or is it better to stent it? Is it better to open it? The wound healing that's associated with all those varieties is poorly described. Yeah. And we're looking at that now.
Any thoughts in terms of whether the fluid wave would work for any of the other MIGS procedures?
Yes.
For eye stents, can you see a fluid wave?
Yes, in fact, we've looked at that, and for example, if we do a circumferential trabeculotomy, we'll see usually a 360 fluid wave.
Okay.
If we open up, if you only open up, let's say you do an eye stent. Yeah. And you're lucky enough to you
have to hit the right spot.
Get let's say you're near a collector channel. Right. B, you're lucky enough that it's in the right position. And C, you're lucky enough that the distal collectors will show you something.
Oh, right.
And the amount of circumferential flow with an eye stent is probably 1 to 2 clock hours. So I'll see maybe a segment light up, but it makes sense because we know the circumferential flow in Schlemm's canal is nil. Right. So it can only access maybe a clock hour to one side. That's it, and that's all they can do. And then the aqueous is going to take the path of least resistance. It's going to go down that collector channel. Doesn't want to go anywhere else. Yep. Because that's the least resistance pathway, and that's it.
And in terms of doing the fluid wave with the eye stent, that would be after you put the stent in, because if you tried before, you won't get the flow. You just probably collapse Schlemm's.
Exactly. So you put your eye stent in, and then you look, and I've almost thought about, well, if I don't see a wave, should I move the eye stent? I don't know. That'd be a great study.
Yeah.
But it's a very simple kind of poor man's angiogram. It's done in the operating room. We don't have a way. I've oftentimes said, if we ask ourselves, what is the outcome marker for glaucoma surgery with a trab? It's a bleb. You look at the bleb, and you kind of got a feel for what's going on. Well, what's the outcome marker for microinvasive glaucoma surgery? Well, we don't have one. We're trying to look at aqueous going in the veins.
Long-term follow-up.
I mean, it's a pressure, but we don't have an outcome marker for MIGS surgery. Right. So that's a big problem. So that's why, at least in the operating room, we can see something.
Yeah, that's great.
So it's a start.
Thanks. Very practical bit of advice.
Well, thanks. Thanks for sitting down and chatting with me.
Yeah, thank you. Take care. That's our show for today. Thanks for your patience as I slowly post new episodes, including a long discussion with Murray Johnstone and a talk about the new glaucoma drug, Ropressa. If you subscribe via iTunes, Pocket Casts, Google Play, Stitcher, or wherever fine podcasts are found, you will get the new episodes as they come out. If you like the show, please leave a rating on iTunes, as this is the best way for others to find it, and tell your friends about the show. Drop me a line at podcast@iGuy.org with your comments. Visit wholelotofrob.com, westcoastglaucoma.com, or follow me on Twitter at Rob Schertzer. Links to all these are in the show notes. Remember to keep fighting glaucoma by early detection so that nobody loses vision from this group of diseases.